Hello, and welcome to Dr. Della Valle's hip replacement preoperative teaching class. Let me start by introducing myself. I am Megan Moore, and I am Dr. Della Valle's physician assistant. You can find me in the office seeing patients with Dr. Della Valle and also in the operating room as well. Next, we have our nurse, Kim DeMarco, and our three administrative assistants, Joy Wilson, Jessica Espinal, and Vilma Zapata. This slide is showing you a brief outline of everything we're going to cover today in this presentation, starting with arthritis overview, requirements for surgery, admission to facility, anesthesia, surgery overview, immediate postoperative recovery, hospital and facility stay along with pain management, postoperative care, and follow-up visits. So I'd like to begin with going over the basic anatomy of the hip and familiarize you guys with some of the terminology I'm going to be using throughout this presentation. The hip is considered a ball and socket joint. So in this analogy, the ball is the femoral head and the socket is the acetabulum. In between the ball and socket, or femoral head and acetabulum, is a layer of cartilage. The cartilage acts like a cushion between the ball and socket, which allows for smooth movement and range of motion for our hip joints when performing everyday activities. So as you'll see on this slide, this is an example of an x-ray that shows what a normal healthy hip joint looks like. The blue arrow is pointing to the space in between the femoral head and the acetabulum, which represents the cartilage in the joint. Cartilage, as I previously mentioned, is a structure in our hip that allows for smooth movement of the hips during various activities such as walking, sitting down, standing up, bending over. Now when we take a look at this slide, here's an example of an x-ray that shows severe arthritis of the hip joint. The blue arrow is pointing to the femoral head and acetabulum. However, you'll notice that there is no space in between those two bones. Quite the opposite of the last x-ray I showed you, the femoral head and the acetabulum are touching. In other words, there is bone-on-bone arthritis. The lack of space in between the bones means that the cartilage is diminished and no longer present, which can occur for a variety of reasons, including years of wear and tear on the hip joint itself, or, in other cases, can be caused by traumatic injury. So, to briefly summarize the previous slides, arthritis is defined as a degenerative joint disease, which is caused by wear and tear of the cartilage in a joint space. Symptoms associated with arthritis include inflammation, pain, and stiffness. So typically, when we first see patients in the office, we discuss a variety of non-operative treatments, including things like anti-inflammatory medications, such as meloxicam or Celebrex. We also recommend activity modification, and this means we discuss with the patients adjusting or avoiding certain activities that exacerbate symptoms. Infrequently, we also occasionally perform steroid injections into the hip joint, depending on case-to-case basis. Once a patient has tried all these non-operative treatments and still continues to have hip pain, we discuss the operative treatment, such as a total hip replacement or hip resurfacing. So next up on this slide, I'm going to spend a little bit of time discussing a few requirements Dr. Della Valle has for all of our patients that need to be completed prior to your surgical date. First one on the list is your preoperative clearance appointment, and this will need to be done by a Rush internist, and that is through Rush University Medical Center. And some of you have already attended this appointment, but just to review in brief, the preoperative clearance appointment is to be completed within 30 days leading up to your surgery. Our admins, such as Joy, Vilma, or Jess, will set up this appointment on your behalf to make this process easy and effortless for all of our patients. At this appointment, the Rush internist will perform a history and physical, obtain blood work, and perform an EKG of your heart. When you're at this appointment, you need to let the internist know if you see any specialty doctors for any health conditions. So this would include things such as cardiologists for your heart, pulmonologists for your lungs, etc. You should also review all the medications that you are currently taking with the Rush internist at this appointment. They will provide recommendations for which medications are safe to continue leading up to your surgery and which medications you should stop prior to your surgery. Our general recommendation in regards to medications that you should stop prior to surgery are anything that can thin your blood, and we would have you stop these medications 1 week prior to surgery. So some examples of medications that can thin your blood include aspirin, ibuprofen, or Motrin, Advil, Aleve, naproxen, and meloxicam. Additionally, things such as multivitamins and supplements can also thin your blood, so we recommend stopping those 1 week prior to surgery. Now, that said, if you are taking a prescribed blood thinner such as Xarelto, Eliquis, or Coumadin for a known medical condition, I am not telling you to stop that medication 1 week prior to surgery. I want to emphasize this point because it is very important that you discuss these specific blood thinning medications with the rush internist at your appointment. Reason being is the recommendations might be different for those specific blood thinning medications. So, for example, some might need to be held 3 days prior to surgery, some a week. So again, just to emphasize, it is important to discuss these specific blood thinners at that appointment. Additionally, if you are currently taking any GLP-1 injection, so this would include things such as Wegovy, Mounjaro, or Ozempic, please let the rush internist know so they can provide specific instructions as to when to stop those medications before your surgery. Typically, we recommend that you hold and stop the injection for the week leading up to your surgery. Lastly, Dr. Della Valle recommends our patients purchase 2 items prior to their surgery, which I will discuss a bit more in depth on the next slide. The 2 items Dr. Della Valle recommends our patients purchase include the following. The first item is going to be a pack of 2 chlorhexidine sage wipes. Again, these come in a pack of 2 and are used prior to surgery, so you must purchase them beforehand. Dr. Della Valle recommends using these sage wipes to decrease the risk of infection. You will use one of the wipes the night before your surgery over the area of where your surgical incision is going to be, so that will either be your left or right hip buttock area. You will then use the second wipe on the morning of your surgery in the same area. I'll elaborate a little bit more in later slides in further detail on how to use these. The second item Dr. Della Valle recommends all patients purchase is going to be an Aquacel dressing. This dressing contains silver, which has antimicrobial properties. Additionally, the dressing is waterproof, which means you will be able to shower after surgery. The Aquacel dressing is something I like to mention many times throughout this presentation to minimize any potential confusion for after your surgery. So again, I will reference the Aquacel dressing several points throughout this presentation. So to dive more in a little more detail pertaining to the dressing, the first Aquacel that is going to be placed on your hip will be in the operating room on the day of your surgery. This is placed by Dr. Della Valle or myself, and the dressing will stay on for the first week or 7 days following your surgery. The Aquacel dressing is waterproof, which means you can shower. After 1 week, you will remove that Aquacel dressing. Once you've taken the dressing off, Dr. Della Valle recommends looking at the incision, making sure there is no redness, blistering, drainage, etc. Please do not wash, clean, use lotion, ointment, or cream on the area. We want to decrease the risk of any infection, so avoid touching, rubbing, fussing with the area of your incision is advised. As long as everything looks good, you will then place the second Aquacel over the surgical incision, and this is going to be the dressing that you have purchased prior to surgery. This second Aquacel will stay on for an additional week or 7 days. If you have any questions or concerns regarding the incision after removing the first Aquacel dressing, please wait to place the second Aquacel and contact the office first. After the second week of the second Aquacel, in which is the one you placed, you will take off the dressing and leave the incision uncovered. This means the incision should be covered for 2 weeks after your surgery and no longer. After removing the dressing, Dr. Della Valle allows patients to leave the incision uncovered and you can shower freely. We recommend avoiding aggressive scrubbing in the shower, just letting the soap and water run off the hip and letting it dry and patting it dry with a towel once you're done. At this time, we still advise that you do not put any cream, lotion, ointment on the incision. Leave it dry and open to air, uncovered. Typically, most incisions are healed by the 5 to 6 week mark. Until then, do not submerge in any water. This includes things such as pools, hot tubs, baths, lakes, etc. So to recap on the 2 items Dr. Della Valle recommends all patients purchase prior to surgery, both the chlorhexidine sage wipes and the Aquacel dressing can be purchased at any one of our DME stores. There are multiple locations for the DME stores for your convenience to pick up. This includes the Chicago office, Munster, Oak Brook, Oak Park, Naperville, Joliet, and Westchester. In your surgery folder you received when you saw Dr. Della Valle in the office, or the one that you received in the mail, there will be a list of all the DME store locations and phone numbers for you to choose from. When you go to one of the locations, all you need to do is walk in and let an employee know that you're having surgery with Dr. Della Valle, and they will assist you in purchasing these correct items. I also like to make patients aware that the Aquacel dressing is $60. If for some reason you are unable to make that purchase, please contact our office and we can discuss options. Another point worth mentioning is that these items, unfortunately, cannot be purchased at any local convenience store such as a CVS, Walgreens, or Amazon. Patients have found similar dressings, but they do not contain silver and/or are not waterproof, which again are both important aspects of why we use the Aquacel dressing. Please do not hesitate to contact the office if you have any questions about these two items, which again need to be purchased prior to surgery. Briefly, this is a slide to show you the list of our DME store, addresses, and phone numbers. Please be sure to check your surgery folder for a list of all these DME store locations that is most convenient for you. For those of you interested, this slide is pertaining to a couple ice machines that our office provides. They are not required for surgery, but if you are interested, we have two versions of the ice machine, and one of which is usually covered by all insurances. Details pertaining to the ice machines are also provided on a sheet in your surgery folder, along with the contact information for those companies that supply them. Should you wish to have them prior to surgery, please contact the number on the sheet to learn more. Alright, I'm going to start to switch gears a little bit and dive more into the details about your surgery, the locations, preparation for the weeks and days leading up to your surgery. Dr. Della Valle operates out of 5 different locations. The first one on the list is Rush Hospital, which is an inpatient facility. Inpatient means anyone having surgery at Rush Hospital will stay at least 1 to 2 nights after surgery. On average, I'd say most of our patients stay 1 night and then leave the next day after their surgery at Rush Hospital. The next 4 locations on the list are all outpatient surgery centers that Dr. Della Valle operates out of. These locations include Rush Oakbrook Surgery Center, Lincoln Park Center for Advanced Orthopedic Surgery, Munster Specialty Surgery Center, and Dunegrass Surgical Suites. Alternative to the inpatient facility, outpatient means that you will have surgery and go home on the same day. There are a few differences between our inpatient and outpatient facilities, so I will try to make those variations clear for the remainder of the presentation. Within the month leading up to your surgery, we want to make sure that you are well prepared for your planned procedure with Dr. Della Valle. As I previously mentioned, our office will schedule your medical clearance appointment with a Rush internist, which will again be scheduled within the 30 days leading up to your surgery. Next requirement includes attending the preoperative teaching class, which all of you are completing today. Next, we'll be stopping by one of the DME stores to pick up the pack of Sage wipes and Aquacel dressing. And lastly, our office recommends setting up your physical therapy appointments ahead of your surgical date. Important to note, all of our total hip replacements and hip resurfacings will begin outpatient physical therapy at 3 weeks after your procedure, which I will touch on more later in this presentation. So, once you've completed all of these requirements within the month leading up to your surgery, you'll be in good shape and well prepared. Within the week leading up to your surgery, you can expect a call from our office regarding surgery consent, reviewing your medications, and potentially sending your post-operative prescriptions. At this time, our office will also review the food and drink policy that Dr. Della Valle requires. The week leading up to your surgery, also, again, be prepared to stop any and all blood thinning medications 1 week prior to your surgical date. So again, to recap, things such as aspirin, Motrin, ibuprofen, Advil, Aleve, meloxicam, multivitamins, and supplements should be stopped 1 week prior. You can also expect a phone call in regards to Dr. Della Valle's food and drink policy. Our food policy leading up to surgery, there will be no eating after midnight the night before your procedure, which also means no eating any food on the day of your surgery. The morning of your procedure, you will stop drinking all fluids 4 hours prior to your surgical time. So, for example, if your surgery is scheduled to take place at 11 a.m., you will not drink any fluids after 7 a.m. that morning. Additionally, Dr. Della Valle recommends all patients drink either the electrolyte packet found in your surgery folder with a 16-ounce water bottle or a bottle of Gatorade, just no red Gatorade, and you'll drink this 5 hours prior to your surgery time. So, to piggyback off the previous example, if your surgery time is scheduled for 11 a.m., you can drink that electrolyte beverage at 6 a.m. And remember, after 7 a.m., no more fluids leading up to your surgery. Of note, for patients with diabetes, if you're going to do an electrolyte beverage, please be sure that it does not contain any sugar. Lastly, a general recommendation we tell patients is to hydrate with lots of water in the week leading up to your surgery so you are well hydrated on the day of your procedure. Also, to review, the night before your surgery, in terms of prepping and cleaning the surgical site, Dr. Della Valle recommends all patients shower the night before your surgery. Following the shower, you'll use that first Sage chlorhexidine wipe you purchased at the DME store. You only have to use the wipe over the surgical site, so whether that be the right or the left buttock and hip area, the morning of your surgery, do not shower. The only thing to do on the morning of your surgery is going to be using that second Sage chlorhexidine wipe in the same exact area. In regards to questions pertaining to what to wear on the day of your procedure, we typically recommend comfortable loose clothing with sensible shoes. You'll work with physical therapy after your procedure once you're feeling good, and slippers and flip-flops aren't conducive when walking with a cane, walker, and crutch. So keep that in mind as you're leaving your home on the morning of surgery. Now, to talk about the day of your surgery. You should plan to arrive 2 hours prior to your surgical time at the hospital or facility that you're having surgery at. You will check in the front with the admission staff, where they will take you through the check-in and registration process. Things you should bring with you on the day of your surgery include a photo ID and your insurance information. Also, please bring a list of your medications and not the physical medications themselves on the day of your surgery. If you already own and would like to bring an assistive walking device, whether that be a cane, walker, or crutch, you are welcome to bring that with you on the day of your procedure. Please note that if you do not have one of these walking devices, that's perfectly fine. You will be discharged from the hospital or surgery center with one of those assistive devices. Once the registration process is complete, you'll be called back by a nurse who will take you to the pre-op area and get you prepped and ready for surgery. Once you are all settled in your preoperative holding bay area, several people will come to chat with you prior to surgery, including myself, Dr. Della Valle, and also the anesthesiologist, who will review the next steps and what to expect as they take you back for surgery. For all hip replacements and resurfacings, Dr. Della Valle uses spinal anesthesia for every procedure. Spinal anesthesia, or epidural, is when medication is put into the lower part of your spine, which then numbs a patient from the waist down. In addition to spinal anesthesia, you will also receive twilight sedation, or conscious sedation, which is usually done through an IV. Oftentimes, patients will ask Dr. Della Valle why he prefers spinal anesthesia over general anesthesia. First of which is that patients typically wake up a bit easier with spinal anesthesia and are less groggy. Compared to general anesthesia, it takes patients a bit longer to come to after their procedure. Another benefit of using spinal anesthesia is you do not need a breathing tube, whereas you do with general anesthesia, which can sometimes cause a sore throat. Finally, there is also less post-operative nausea and vomiting associated with spinal anesthesia when compared to general. In these next few slides, I will discuss the details pertaining to the surgery itself and what's involved during a total hip replacement. Prior to your surgical date, our team sits down to review each individual surgical case we have on our schedule for the upcoming week. At this time, we make sure your medical clearance is complete, in addition to discussing x-rays and what components we will use for your surgery, so everything is ready and available on the day of your procedure. A few details patients often ask about is how long is the surgery, what approach does Dr. Della Valle use, and how big is the incision. Surgery itself takes about 90 minutes. Dr. Della Valle performs a posterior approach for all of his hip replacements and hip resurfacing procedures. The incision size for a total hip replacement and hip resurfacing vary a bit. For all total hip replacements, the incision is approximately 4 to 6 inches. For all hip resurfacings, the incision size is a bit bigger, approximately 8 to 10 inches. In regards to the exact location of your incision, it will be placed on the lateral aspect of the buttock. So, to imagine where it will be, if you were to stand up from your chair out of your seated position and let your arms fall naturally to your sides, the incision will be placed approximately 1 to 2 inches behind your hand. Keep in mind, this is the area we recommend that you use the Sage Wipe the night before your surgery and the morning of your surgery, as I previously mentioned. On this slide, you'll see an example of an x-ray that demonstrates a total hip replacement. The components utilized at the time of surgery are composed primarily of titanium and cobalt chrome alloy. We also use a polyethylene liner, which is made of incredibly strong plastic. I will review each of these components on the next slide. The components used for a total hip replacement are all pictured in the photo on your screen. These components are all modular, which means they come in separate pieces, so, if necessary, they can be changed at some point in the future. The femoral component, or stem, is composed primarily of titanium and has a porous coating exterior. The head of the femur, or the ball prosthesis attached to the top of the stem, is comprised of cobalt chrome or ceramic. The acetabular component, or the cup, is primarily titanium with a porous coated exterior. As you've heard me mention a couple times, both the stem and the cup have a porous coating exterior. This is important because it allows for the bone to grow into the implants, which is important for longevity of the implants. Lastly, there is the polyethylene liner, which is made out of very strong plastic. This liner is locked into the cup and allows for smooth movement of the head component. Next, I'm going to take a few moments to explain a little bit more of the details and steps involved in a total hip replacement. As I mentioned, I assist Dr. Della Valle in the operating room, so I will be there on the day of your procedure as well. Dr. Della Valle begins by making a 4 to 6 inch incision along the posterior lateral aspect of the hip, which allows good exposure for the hip joint. He then proceeds to remove the arthritic bone within the hip, including the head of the femur. Once the head is removed, he will prepare the femur and acetabulum in order to place the components. After the femoral stem is placed, along with the impaction of the cup, he will then put in the polyethylene liner into the cup. Following insertion of the poly liner, Dr. Della Valle then impacts the head of the femur onto the neck and carefully reduces the hip back to its native position. The incision is then closed with 3 layers of dissolvable suture, all of which are underneath the skin. The Aquacel dressing is then placed over the incision and covering the surgical site. After your surgery, you will safely be rolled back to the recovery room where you'll be cared for by the nurses and anesthesiologist. Dr. Della Valle also performs another kind of hip procedure known as a hip resurfacing, which serves as an alternative to a total hip replacement. Patients looking to return to high-level performance activities would be a good candidate for this procedure. In comparison to a total hip replacement, there are a few similarities and differences I want to mention. Similar to a total hip replacement, Dr. Della Valle will still perform a posterior approach to the hip. Unlike a total hip replacement, a hip resurfacing incision is slightly longer, usually measuring 8 to 10 inches in length. Of note, patients with poor bone quality would not be ideal candidates for this procedure given the increased risk of femoral neck fractures. To review the components used during a hip resurfacing procedure, there are 2 components utilized at the time of surgery, one of which includes a highly cross-linked vitamin E polyethylene acetabular cup and a cobalt chromium alloy femoral head. Now, I will briefly review the steps involved in a hip resurfacing procedure. There are some similarities and differences when compared to a total hip replacement, which I will review. Dr. Della Valle begins by making an 8 to 10 inch incision along the posterior lateral aspect of the hip, which allows for exposure of the hip joint. He then proceeds to expose the hip and prepares the acetabulum by using special tools to ensure the socket has a smooth surface. He then places the cup into the acetabulum, ensuring a good press fit. Next, Dr. Della Valle uses a special tool that shaves and shapes the femoral head. So, unlike a hip replacement, the femoral head is not removed but instead shaped to allow for a perfect fit of the femoral head component. Once the femoral component is impacted onto the shaved femoral head, the hip is carefully reduced into its native position. Similar to a hip replacement, the incision is closed with the same 3 layers of dissolvable suture, all of which are underneath the skin. The Aquacel dressing is placed over the incision. This whole process takes approximately 80 to 90 minutes. As you might have heard me mention, both hip replacement and hip resurfacings have the same closure technique. We use 3 layers of sutures, all of which are underneath the skin and will dissolve over time. This means nothing will need to be removed from the incision after your surgery, such as staples or superficial sutures. Once we have closed the surgical wound, we cover the incision with an Aquacel dressing in the operating room. As I've previously mentioned, this Aquacel dressing will stay on for 1 week after your procedure. Once your surgery is complete, you will be safely taken back to the recovery area and will be monitored closely by the nurses and anesthesiologist. In the recovery area, you'll spend a couple hours resting as the spinal anesthesia wears off. I like to make patients aware that if you find you're unable to move your toes right away after surgery, that is completely normal and it will diminish with time. The nursing staff will care for you, administer medication if needed, provide any food or drinks to ensure that you're comfortable in the recovery area after your procedure. Now I'd like to highlight a few differences when having surgery inpatient at Rush Hospital or outpatient at one of our surgical facilities. If you are having surgery at Rush Hospital, which means inpatient, again, you will be required to stay overnight at the hospital for at least 1 night. Most of our patients leave the following day after their procedure, but depending on a patient's needs, sometimes it is 2 nights. In order to be discharged from the hospital, you will need to be cleared by physical therapy and occupational therapy. The goal is to make sure every patient feels safe and is comfortable prior to going home. For our inpatients, physical therapy may or may not work with you on the day of your surgery. It all depends on the timing of your case in the day and how you are feeling. If you don't have physical therapy see you on the day of your procedure, they will come and see you the following day. As previously mentioned, all patients will have their own private room on the orthopedic floor at Rush Hospital, in which you will be transferred to once you're comfortable and stable in the recovery area following your procedure. As a reminder, whether you are having inpatient or outpatient surgery, if you have an assistive device at home and you want to bring it with you on the day of your surgery, that is perfectly fine. However, if you do not have an assistive walking device, don't worry, you will be given and discharged with one from either the hospital or surgery center, which includes either a cane, walker, or crutch. For those of you having surgery at one of our outpatient facilities, on average, most of our patients are at the surgical facility for a total of 6 to 8 hours. This could be a little bit more or could be a little bit less. It just depends on the individual. Similar to our inpatient setting, in order to be discharged from the surgery center, you will work with physical therapy following your procedure to make sure you're comfortable and able to ambulate with an assistive walking device following your surgery. A physical therapist will work with you following your procedure to show you how to perform your daily activities safely, which includes practicing going up and down stairs, how to safely put on your clothes and shoes, etc. As far as restrictions go after having a hip replacement or hip resurfacing, Dr. Della Valle only has one general guideline that he recommends his patients follow. He advises that all patients avoid extreme ranges of motion following their hip replacement or hip resurfacing. Extreme ranges of motion could include any position that puts the hip at risk for dislocating, so use your better judgment, and if something seems too extreme, please avoid that position or movement. Once you are home from the hospital or surgery center following your hip procedure, Dr. Della Valle wants you to take it easy for the first 3 weeks of your recovery. This means no form of any exercising or formal physical therapy. You will start physical therapy at the 3-week post-operative mark, but not any time sooner. We recommend setting up your physical therapy appointments ahead of your procedure due to some locations filling up sooner than others. Again, to reiterate, we advise you to schedule physical therapy before your surgery date, with the first appointment being no sooner than the 3-week mark after your surgery. Dr. Della Valle recommends using one of our physical therapy locations at Midwest Orthopedics at Rush. We have several different locations to choose from, and there is a list in your surgery folder of each location, address, and phone number. If you need any help scheduling these appointments, please don't hesitate to contact our office. Dr. Della Valle recommends attending 3 times a week for at least 6 weeks. Remember, Dr. Della Valle's one true recommendation when it comes to hip precautions after surgery will be avoiding extreme ranges of motion. Additionally, remember he advises all patients use some form of an assistive walking device at all times for the first 6 weeks following surgery. In your surgery folder, you will have a sheet that looks similar to this slide, which provides locations, addresses, and phone numbers for you to schedule. Next, I want to spend some time reviewing your medications that will be prescribed for you after surgery. This is a chart of your post-operative medications, and inside your surgery folder, there will also be a similar chart for you to review. For those of you having surgery at one of the outpatient facilities, these medications will be called into your pharmacy by myself or our nurse Kim. When one of us gives you a call within the week leading up to surgery, we will send this group of medications to your pharmacy so you can pick them up prior to surgery. Of note, for those of you having surgery at Rush Hospital, you will be discharged with these prescriptions when you leave the hospital. Additionally, Dr. Della Valle has started adding 2 medications for this protocol, including an oral steroid and oral tranexamic acid. If you are prescribed these medications, depending on your surgical site, Kim or myself will have that conversation with you when we give you a call in the week leading up to your surgery. For now, I will stick to the list seen on your screen. First medication on the list is meloxicam or Mobic, which is an anti-inflammatory medication. This helps to decrease inflammation, swelling, and pain after your surgery. You will begin taking the meloxicam the day after your surgery, 1 tablet once a day. I also want to mention, in certain scenarios, we sometimes prescribe Celebrex or celecoxib to patients if they are already taking that anti-inflammatory medication or cannot tolerate the meloxicam. Celebrex is similar to meloxicam and works as a 24-hour anti-inflammatory medication in which you take 1 tablet once a day. Next medication on the list is aspirin. This is the blood thinner we use to decrease the risk of blood clots post-operatively. Similar to the meloxicam, you will begin taking the aspirin the day after your surgery. You will take 1 tablet in the morning and 1 tablet in the evening. The aspirin will be taken for a total of 3 weeks after your surgery, so you should have 42 tablets total in the prescription. Next medication is Senokot, which is a stool softener, and the reason we prescribe this is due to a lot of the medications we give you on the day of surgery and some of the pain medication we prescribe you for after surgery, which can cause constipation. So we utilize the Senokot to counteract those side effects. You can safely take 1 to 2 tablets of the stool softener up to twice a day. The next 3 prescriptions I'm going to review are for postoperative pain and should be taken in this order. First step in Dr. Della Valle's pain management stepwise protocol is Tylenol. As you can see, Tylenol, acetaminophen, has a number 1 next to it, which indicates this is the first medication you should take for pain control. The Tylenol/extra strength acetaminophen is the first medication Dr. Della Valle wants all of his patients to start when it comes to postoperative pain control. You can start this the night of your surgery or the morning after and can safely take 2 capsules up to 3 times a day, not exceeding more than 3,000 milligrams a day. So, what we recommend is the day after surgery, taking 2 capsules of the Tylenol in the morning, 2 capsules in the afternoon, and 2 capsules in the evening. Again, it is important to stay ahead of any potential postoperative discomfort you might experience. We do not recommend immediately jumping to the next 2 medications that I'm going to review. Taking the Tylenol throughout the day consistently in adjunct with the meloxicam is proven to be an effective baseline in the pain management protocol, which aids in decreasing the use of the opioid medications. Next prescription medication in the pain management protocol is Tramadol. Tramadol is a weak opioid, which, as you can see, is the second medication recommended in the stepwise medication regimen. You can safely take 1 to 2 tablets of the Tramadol up to 3 times a day. So, the morning after your surgery, you will start by taking the meloxicam, aspirin, Senokot if needed, gabapentin, and the Tylenol. If you are feeling comfortable with just those medications, you do not need to take any other. However, let's say you've taken the meloxicam, aspirin, gabapentin, and Tylenol and are still feeling some discomfort. You can add in the tramadol, which again, you can take safely 1 to 2 tablets up to 3 times a day. The last medication on the list we prescribe is oxycodone. Oxycodone is a strong opioid pain medication and, as you can see, is number 3 on the list for the stepwise pain medication protocol. So, if you are taking the meloxicam, aspirin, Senecot if needed, have added in the gabapentin, Tylenol, and tramadol, and continue to have some breakthrough discomfort, you can add in the oxycodone as needed. The oxycodone is the last line in the pain medication regimen and should be taken in between the other medications. You can safely take 1 tablet of the oxycodone every 4 hours. Please note, the 2 opioid medications, including tramadol and oxycodone, should be weaned off of. This means that they should be slowly discontinued, slowly decreasing the dose when ready to stop taking them. We do not recommend abruptly stopping these medications if you have been taking them on a daily basis due to the possible side effects. Last thing I want to mention in regards to any of these prescriptions is that if you need a refill on any of these medications, please contact the office. Kim or myself are happy to send in a refill electronically to your pharmacy. Please do not hesitate to contact myself, Kim, or Dr. Della Valle if you have any questions about these medications. We are here to provide guidance and reassurance after your surgery. Moving on to the potential associated complications and risks associated with a hip replacement or hip resurfacing procedure. To briefly review, first on the list is anesthesia. Anytime anyone undergoes surgery that receives anesthesia, there can be problems with your heart or lungs, which is why we have you see a medical doctor in advance to make sure you are not at high risk. Dislocation. This is when the ball comes out of the socket. You would know if this occurred because it is very painful and does require you to go to the emergency room so it can be put back into place. This is why Dr. Della Valle has his general guideline of avoiding any extreme ranges of motion following your procedure to avoid the risk of dislocation. Difference in leg length. Following your surgery, if you feel within the first several days to weeks your legs are unequal or feel off, first thing you should do is contact Dr. Della Valle or our office to discuss any kind of discomfort or discrepancy you might be feeling. Another thing I like to mention is that we do not recommend you self-treat by using a shoe insert or shoe lift. So if you do have any concern, give us a call and we're happy to have you come into the office to have you evaluated. Fractures. Of course, we do not anticipate this to happen at the time of surgery. However, Dr. Della Valle does use tools that could cause the bone to fracture. If this does happen, we would let you know and possibly take measures to protect your weight-bearing status after surgery. However, if it does not, we allow all patients to put full weight on the operative side immediately following surgery with the use of an assistive walking device. Loosening or failure of components. One way that this can happen is wear. So there are certain things we do not recommend that you do after having your hip replaced that could cause early wear of the plastic liner. No running, jumping, high-impact activity, which are all things that could cause early wear of that plastic liner. Things that you can do to stay active after having your hip replaced includes walking, elliptical, swimming, biking, golfing, and even pickleball. Hematoma. This is an accumulation of blood in the joint. Usually, the body does a good job of getting rid of it. However, if it does not, we may need to evacuate the hematoma to decrease the risk of infection. Blood clots. Blood clots after surgery can be caused by prolonged period of immobility. A blood clot can form in your legs, which is referred to as a DVT, and sometimes can travel to your lungs, which is called a PE, which can be fatal. We take many proactive steps to counteract the risk of blood clots after your surgery, which include the use of aspirin, which is an anticoagulation medication, and we have you take that twice a day for the first 3 weeks. Additionally, we recommend standing up and taking small steps around your home, whether it's to the kitchen or down the hall, to keep the circulation in your legs moving as well. blood vessel injury. There are blood vessels located in the hip joint, and if injured, can cause increased bleeding at the time of surgery. Dr. Della Valle specializes in hip and knee replacements and is very familiar with the anatomy and tries to avoid these structures. Nerve injury. There are nerves located in the hip joint. If injured at the time of surgery, you could experience numbness or weakness. If you notice some point after your surgery you have either of these symptoms, please contact our office so we can discuss if there is any issue or concern. Infection. Having an infection leading up to your surgery or developing one after your surgery is something our office takes very seriously. Dr. Della Valle provides clear instructions and recommendations for a protocol in regards to infection in order to decrease your risk. His recommendations are as follows. Before your surgical date, the first thing we need from you is to be infection-free for 2 weeks leading up to surgery. In addition to being infection-free, Dr. Della Valle recommends all patients avoid any dental procedures, including routine cleanings, and colonoscopies leading up to your surgical date. If something does come up within those 2 weeks leading up to your procedure, please contact the office to discuss. There is a chance we would reschedule your case depending on the situation. Following your knee replacement, Dr. Della Valle recommends all patients avoid any dental cleanings, elective invasive procedures, and colonoscopies for 3 months following surgery. Please look at your calendar, and if you know you have any planned procedures, we recommend rescheduling. Also, if you were to develop an infection of any kind, such as a tooth infection, this is something our office would want you to get taken care of as well. The important takeaway is to keep our team informed so we can be in coordination of your care should anything arise. Once those 3 months are complete, you can proceed with elective procedures, including dentist appointments and colonoscopies. Dr. Della Valle recommends taking prophylactic antibiotics prior to any invasive procedure, including dental work and colonoscopies. The antibiotics required you to take 4 tablets 1 hour prior to your planned procedure. The reason we are so cautious with infection, both before and after surgery, is because if you did develop an infection following your knee replacement, it could possibly involve the hardware in the knee, which is very difficult to treat. Sometimes it could involve another surgery or 2, which includes removing the implants in addition to treatment with IV antibiotics for a minimum of 6 weeks. This is something we certainly want to avoid, so please don't hesitate to contact the office if you have any questions or concerns regarding infection. Some key points to highlight when it comes to post-operative care after your surgery. The first Aquacel dressing placed on your hip in the operating room on the day of your surgery will stay on for 1 week. You will remove that dressing after 1 week, inspect the area but do not clean it, and proceed to place the second Aquacel dressing over your incision. This second dressing will be the bandage that you purchased at one of our DME stores. Once the second week is complete, you will take the dressing off and leave the incision open and dry to air. You do not need to put on another bandage of any kind over the incision at this time. You can also continue to shower as normal, letting the soap and water run off the incision. At this time, we still ask that you avoid putting any lotion, cream, or ointment on the incision, and we ask that you do not submerge in any kind of water until the incision is entirely healed. Watch for signs of infection, which can include extreme redness, warmth, drainage, new onset hip pain, fevers, or chills. Swelling and bruising are definitely part of the normal recovery process following a hip replacement or hip resurfacing. We recommend elevating and icing regularly, including 20 minutes on with an ice pack, making sure that a towel is between your skin and the ice. Reminder to continue using your assistive walking device, whether that be a cane, walker, or crutch, at all times for 6 weeks following your surgery. Dr. Della Valle recommends no driving for the first 3 weeks after your surgery, regardless of the operative leg. At the 3-week mark, if you are no longer taking any of the narcotic medications and feel comfortable, you may begin to drive. Lastly, as far as returning to work goes, if you need any paperwork filled out, please send that to our office via fax, email, or personally drop it off. We allot up to everyone having 12 weeks off of work if needed, and if you'd like to return sooner, we can revise paperwork. Dr. Della Valle will tell you that most patients can do most things by 6 weeks. However, if you get to the 12-week mark and find that you are unable to return to work, at that time we would recommend having an FCE performed, which stands for Functional Capacity Evaluation, which is something a physical therapist would perform and unfortunately is an out-of-pocket cost for patients. Rarely does it come to that. Following your surgery, your first follow-up appointment will be 3 weeks after your procedure, which will be done via telemedicine with either the nurse or PA. This appointment is scheduled prior to your surgery, and you can find the appointment details in your surgery folder. At this visit, we ask that you are prepared to show your incision on camera in order to evaluate and assess your healing progress. If for whatever reason you feel like your appointment needs to be in person, please contact the office and we are happy to accommodate. The next appointment after your 3-week visit will be at the 6-week post-operative period. This appointment will be made and scheduled for you after you attend your 3-week telemedicine. The appointment at the 6-week post-operative period will be in person, and at that time you will come in and get new x-rays and chat with Dr. Della Valle. If all is going well at that time, Dr. Della Valle will ask to see you back in 1 year for your annual evaluation, and from there begin to space out your visits, being the next one in 2 years, and then 5 years, and so on. I also want to provide you with 2 important resources that Dr. Della Valle recommends all patients review and utilize for education and post-operative support. DellaValleOrtho.com has great information and commonly asked questions. We also offer a free texting service that sends you messages both before and after your surgery that provides great information, surgery tips, and recommendations with your recovery. Patients love this service, and we cannot recommend it enough. You can start by texting the word JOIN to the number 312-248-6776, and the automatic text will begin leading up to your surgery and for several weeks after. I also want to mention that if you receive a call from our research department, Dr. Della Valle encourages patients to hear them out, and you might be a candidate for one of the studies he is involved with. You do not have to participate, but we ask that you kindly hear them out. That concludes the preoperative teaching class. Dr. Della Valle and our team look forward to helping you through this journey and recovery process. Thank you.